So let's talk about the factors that affect breathing. So we have different, we have chemoreceptors, which detect changes in chemicals in the body, so like oxygen, carbon dioxide, pH. We have proprioceptors that detect changes in like joint movements, stretch receptors that detect pressure changes, so like when the thoracic cavity gets very large. And then irritant receptors, which allow us to get rid of potential irritants from our system, so to make us sneeze or cough. We have two types of chemoreceptors, central and peripheral. Central chemoreceptors are found within the CNS, and they help to monitor the pH of our cerebrospinal fluid. Cerebrospinal fluid, or not cerebrospinal fluid, pH is changed by the amount of carbon dioxide in our system. Carbon dioxide actually produces it's a better word, acidic pH. So the more carbon dioxide in our system, the more carbonic acid that can be produced, which produces a very low or a much lower pH than we're supposed to have. And so that change is going to be relayed to the medulla and cause us to increase breathing rate so that we blow off more carbon dioxide. In the peripheral body, we have within our blood vessels and the carotid and aortic arteries, we have chemoreceptors that detect changes in carbon dioxide levels as well as pH. There's also minimal changes that are associated with oxygen levels. So oxygen doesn't drive breathing. Most people think, well, oxygen, you breathe because you need more oxygen. But actually, that's not true. Typically, we breathe to get rid of carbon dioxide, and then we pull oxygen in. But oxygen receptors are not that sensitive. Oxygen receptors aren't that sensitive unless you have a buildup of carbon dioxide and your carbon dioxide receptors become insensitive because they are constantly being bombarded. Think about sitting at home and having a child talk to you. Mom, 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 mom. My kid, I have 4, and my kids have done that to me. And at some point, you stop listening. You just can't do it. And I can actually have conversations I have in the past where I don't remember talking to them because I was focused on something else. And so they asked if they could do something. I said yes. And the next thing I know, I'm like, why are you doing that? They're like, you said I could. I'm like, okay. I was not paying attention to what I was saying. So that doesn't count. And they're like, well, not my fault. But the issue there is anytime you are bombarded with the same stimulus over and over and over and over and over again, eventually you're going to become insensitive to that stimulus. So when people have a huge amount of carbon dioxide in their system, like with emphysema, their carbon dioxide receptors are getting bombarded with the stimulation, and they become insensitive. And what that does is it causes us to need our drive to breathe becomes the low levels of oxygen. And so you decrease the amount of oxygen in your system, and that causes you to need to breathe. Because your hypoxic drive is actually driving you to breathe, giving patients that have emphysema high levels of oxygen could actually be a problem, because if they have a lot of oxygen in their system, they no longer have the drive to breathe. Does that make sense to everybody? And if not, please ask questions. listen to these videos, and then come in with questions. I'm doing everything I can to help. You have to watch the videos and then write down the questions so you can come in and bring them to me or email me, okay? This is one of the animations, but if you look in your chapter or exam 4 animations assignments, I have animation PowerPoints. You can just click in the animation PowerPoints and you'll find all of the animations for the different videos I want you to watch. This is one of those videos that I've posted, so you can get it from here or you can get it from the animations PowerPoint. One disorder associated with breathing is called sleep apnea. So apnea is the cessation of breathing. When you hold your breath, you are voluntarily not breathing. But apnea can also be caused because you have pressure that is closing off the airway. So in this case, the tongue is falling to the back of the mouth. That can cause problems with breathing. Sleep apnea, there are 2 types of sleep apnea. Obstructive sleep apnea is the most common form of sleep apnea. The other is called central sleep apnea, and in that case, your brain stops sending signals. That's a more severe form of sleep apnea. The machine that we use to help us when we have sleep apnea is called a CPAP machine. And so this is just a short video on the CPAP.
Obstructive sleep apnea, or OSA, is a potentially life-altering and life-threatening breathing disorder that occurs during sleep. OSA causes a person's upper airway to repeatedly collapse, causing cessation of breathing or an apnea. In addition, OSA also causes inadequate breathing or a hypopnea, in addition to snoring and ultimately sleep fragmentation. Prevalence of OSA is estimated at 5% of the adult population. Approximately 18 million people suffer from sleep fragmentation, resulting in chronic daytime sleepiness. Left untreated, long-term effects of OSA include hypertension, stroke, cardiac arrhythmias, and myocardial infarction. Short-term effects include decreased quality of life, excessive daytime sleepiness, restless sleep, poor judgment and concentration, morning headaches, and irritability. Continuous positive airway pressure, or CPAP, is the most widely used treatment for OSA. CPAP is typically applied via a nasal mask. CPAP delivers
Can also be applied via a full mouth mask, full face.
Split to prevent the collapse of the pharynx.
Okay. Really? There we are. Okay, I knew I could find it. I have sleep apnea and I use a full face mask. And I will tell you that it is amazing. The first, probably, I'm going to scare people, but 6 months can be pretty intense. They're hard to use the mask because you have pressure on your face in areas that you normally don't have pressure, and so it can be very uncomfortable. You can get bruising, you can get sores form around the nasal region, and so it can be very uncomfortable. But my sleep is so much better now, and after you've worn the mask for a while, your face gets used to it, the skin gets used to it. You get kind of a thicker skin in those areas, like kind of like a callus. And so you don't have the pain associated with it, and then you can just breathe freely. So it's wonderful. So we're going to talk about what influences the movement of air into the lungs. There are 2 basic factors that influence this. The pressure gradient, so the difference in pressure of the atmosphere and the pressure in the lungs. And then resistance. Resistance is going to be anything that opposes that movement of air. So airflow is going to be the difference between the pressure gradient divided by the resistance. And so what causes resistance? The decrease in elasticity of your chest wall can provide resistance. You're not able to exhale properly, so you're not going to be able to inhale properly. Bronchial diameter. If you have a smaller bronchioles, you're not going to be able to get as much air through. And then if you have increased surface tension causing your alveoli to collapse, that's going to decrease the ability of air to move in. And that's associated with this disorder called acute respiratory distress syndrome, which is often seen in infants that are premature. So I told you that pulmonary ventilation had two definitions. The first one was just breathing, was pulmonary ventilation, and the second one was the amount of air moving between the atmosphere and the alveoli in a minute. So there are different measurements that we take to determine our pulmonary ventilation. A tidal volume is the amount of air that we move per breath. Our respiratory rate is the amount of air, or the amount of breaths we take per minute. So our pulmonary ventilation then would be our tidal volume times our respiratory rate. So if typical tidal volume is about 500 milliliters for an average adult, and most adults, again, on average, take about 12 breaths per minute. So if we do the math, 500 times 12 equals 6 liters of air per minute, or 6,000 milliliters of air per minute, but that's 6 liters, okay? But some of that air doesn't actually get to the alveoli. So there's a region in our lungs called the anatomic dead space where gas exchange doesn't occur and the air doesn't actually move into the alveoli. So that's about 150 milliliters of air. So we have to take that away from each of our breaths. So we have 500 milliliters minus the 150 milliliters of anatomic dead space. And then multiply that by 12, and we get about 4.2 liters of air moved per minute. The deeper we breathe, the more air we will move. So how do we determine this? We use this structure called a spirometer. Spirometers measure the amount of air that we move. We actually can use spirometers to measure other things as well, such as inspiratory capacity. So inspiratory capacity is the amount of air that we can take in with the tidal volume and the inspiratory reserve volume. So above and beyond the normal air that we breathe in, we can actually take in extra air. Think about when you were getting ready to jump off a diving board. You take a deep breath, you're like, and then you jump. So that's that inspiratory reserve volume that you're using. We can also measure the expiratory reserve volume. So typical expiration above and beyond that is the expiratory reserve volume. So think about when you're blowing a balloon up. You take a breath in, and then you blow. But you blow harder than a normal breath out until you get that balloon really big, right? That's the expiratory reserve volume. So if you're looking at the total vital capacity air that moves, you would have to add the inspiratory reserve volume and the expiratory reserve volume to the total, to the tidal volume. And then the total lung volume will include the anatomic dead space as well, okay? So air moves in and out, but then we also have alveolar and systemic gas exchange as well as gas transport, and that's going to be in our next video. Bye for now.